Good afternoon, all. Thank you for joining today's session of Arizona Community Grand Rounds. We'll just give a few minutes or so, not too many, for folks to connect, and then we'll get started with today's presentation. Well, welcome everyone to today's presentation of Arizona Community Grand Rounds. I'm Mark Carroll. I'm with Health Choice Arizona, Blue Cross Blue Shield of Arizona, and we're very pleased to co-support, sponsor these sessions with the NARB Institute, and especially appreciative of the leadership of Mary Jo Gregory, President and CEO of the NARB Institute, who's with us today. We host rounds about once a month, and we look forward to your ideas moving forward for presenters, both from within Arizona and nationally. We've been very pleased over the past year to have a series of just great, fantastic presenters with expertise across a wide range of skills and backgrounds. And today is no exception, so we're gonna jump right in. Today we're joined by Tom Betlach. Tom asked me to keep his presentation or his introduction short, because it's quite impressive in its details, but I'll just note and highlight that he's the former director of AHCCCS, the Arizona Healthcare Cost Containment System, the Medicaid system in Arizona. Tom's also the former president of the National Association of Medical Directors. Currently, Tom serves as a partner for Spire Healthcare Strategies, and he is also a fellow with the NARB Institute. Tom, really looking forward to your presentation today. I must say that I've really enjoyed the opportunity to work for and with you over the years. It's a real pleasure to have you join us today. Over to you.
Thanks, Mark, and thanks so much for the kind introduction. Mary Jo, thanks to you and the team at NARBA for hosting these as well. It's a pleasure to be with everybody this afternoon. And I'm going to spend some time talking about Medicaid, some of the trends that we're seeing nationally, some of the opportunities and challenges that the program is facing, spend a little bit of time digging in a little bit on some of the unique aspects of what we see happening in Arizona, and then really look ahead in terms of some of the areas that we can expect to see policymakers and the Medicaid program evolving here over the next few years. So first, just a few level setting slides, just so that everybody's on the same page. But Medicaid was established in 1965 with Medicare. It was sort of an afterthought. If you go back and read the history, a lot of the focus was on the creation of the Medicare program, offering assistance to seniors and those with disabilities. And really Medicaid was thought of as something that would be small, kept relatively contained over time. And you're going to see, obviously, that has not been the case as the program has really evolved. It's unique in its federal-state partnership, where both the federal government and states are equity partners. The federal government puts up a share of the cost. The states have to present a match in order to draw down federal dollars. As part of that tension and relationship, the federal government establishes some expectations as it relates to eligibility, certain services that must be delivered, access requirements in terms of access to care. And the states have a lot of flexibility in terms of how they think about establishing their Medicaid program and operating the Medicaid program in terms of eligibility. Do they want to go above federal minimums? Do they want to do the ACA expansion, delivery system, fee for service, managed care, some combination thereof, rate structures in terms of payments, how closely are they tied to, say, for example, Medicare as a benchmark? Medicaid has grown to the largest insurance program in the United States. You'll see some numbers here in just a second. And remember, Medicaid's an income-based program. And so I just put some data down there so that people can get a context in terms of, as we talk about a single individual at 133% of the federal poverty limit, $17,000 in a family of four $35,000. So again, an income means tested program in order to qualify for Medicaid. Some data that we see around the Medicaid program: 80 million lives covered, hit a new threshold here within the last couple of months. 1 in 3 kids are enrolled in the Medicaid program nationally. Covers 50%, over 50% of the births here in Arizona, 50% of births all nationally. 1 in 7 elderly. So people think of the elderly population, the age population, they often think of Medicare, but Medicaid covers a significant portion of that population, individuals who are dual eligible for both Medicare and Medicaid. 10 million people with disabilities, 25% of all behavioral health spending, and the total cost of the program are now actually in excess of $600 billion. This is a couple of different slides that look at some of the trends we've seen going way back in time for Medicaid. So you see the enrollment, which is on the y-axis on the right-hand side, where it's grown to, approaching 80 million, now over 80 million in terms of the overall number of enrollees, just rapid amounts of growth occurring, and a large amount of growth here since the pandemic started. And the spending to mirror that, right? And so with the growth of the individuals being served by the program, the overall spending has paralleled that. Then you see Medicaid compared to private insurance and Medicare in terms of the growth of a per individual. And over time, Medicaid has really been at a lower level of growth as it relates to overall costs of care as compared to private insurance and Medicare. This is a very busy slide, and so I'm not going to spend a lot of time on it, but I'm going to orient the audience to it just so that you have context of what this slide tells you. And let's start on the left-hand side where it says all enrollees, 409 billion. So this data is a little old, obviously, but it gives you a context of where the spending goes in the Medicaid program. So 3.4% goes to Medicare premiums, so paying Part B premiums and other costs associated with Medicare for those individuals that are dual eligible. 16.2% going towards institutional care for long-term services and support, so nursing facilities. 13.8% for non-institutional LTSS. So this is home and community-based services. It's homemaker services, attendant care services, services to serve individuals so that they can stay in their home or in the community rather than going into an institutional placement like a nursing facility. 33% going to managed care, 2% going to drugs, 14.2% going to non-hospital acute care, and then 17.4% going to inpatient and outpatient. This is the distribution of the spending associated with population. So on the left-hand side is the population, the percent of the population that falls into different buckets: aged, individuals with disabilities, newly eligible adults, non-newly eligible adults. So think of pregnant women and other adults, and then children. And you can see obviously on the right-hand side, expenses, children disproportionately less expensive to cover, right, than other populations. And for example, individuals with disabilities cost more than twice as much from a percent of expenditures as compared to population. So just some context on where the dollars go in terms of the population served. Now, Medicaid's not heterogeneous too in terms of the costs and the different complex populations that are served by the program. This is Arizona data. So the overall population is a little over $6,000 per member per year. But if you get to an individual that has serious mental illness, you're talking about a population that's approaching roughly $30,000 per member per year. Individuals that might be aged requiring long-term services and supports, or individuals with developmental disabilities, over $35,000 a year. Kids with special health care needs in Arizona, we refer to that as the CRS program. And when you add all their expenses together, $25,000 per year. And kids in the foster care system, or DCS, and that's roughly $15,000 a year, with over 80% of those expenditures being behavioral health related expenses. In addition to all the growth we've seen in terms of enrollment and costs, we've also seen a growing rate of the Medicaid program served by managed care. States opting to pursue and leverage managed care insurance companies, both nonprofit, for-profit, in terms of contracting with them to serve as part of the delivery system, to help organize care, establish care management infrastructure, be able to be more selective in terms of the network establishment, and look at other types of tools that can be leveraged through the flexibility of managed care that wouldn't normally be available in a fee-for-service system. And obviously in Arizona, this is nothing new to us. If you go back to the creation of the program known as Access, it was created in 1982, so 17 years after Medicaid was created, the last state to choose to create Medicaid within its state. And it came in as a mandatory managed care state, with the exception of the Native American population, which was a first of its kind at that point in time. No other state had established a mandatory managed care program. And so you can see really the program evolving significantly over time. We're now over 50% of the program is managed care from an expenditure perspective. In terms of lives enrolled in managed care, it's approaching 70%. And this slide just tells you sort of by state, what percent of the population is enrolled in managed care. So those over 75%, which includes Arizona, those between 50 and 75%, those between 1 and 50 in those states that don't have managed care, oftentimes because they don't have enough population. And then the one state that's changing on this is North Carolina is just starting managed care. They're going live this year, went live late last year. And Oklahoma is in the process of bidding managed care as well. So that's another state that will be going to managed care. One other note on managed care is that as we've seen its growth, we've also seen a growth in taking on more complex populations. So this slide gives you an indication of how the growth of Medicaid managed care for long-term services and supports has evolved over the last many years. So if you go back, there was just a handful of states, including Arizona back in 2004, that had what's known as MLTSS programs. And then when you fast forward to 2017, there's 24 states that have created an MLTSS program to serve individuals that require nursing facility, home and community-based services, so institutional level of care as it relates to their Medicaid services. And then finally, this is just a look at the different populations by the 40 states that have managed care and what percent of the population is served by that. So again, just to orient you to this slide, all beneficiaries, 33 states have greater than 75%. And then you can see the different demarcations as it relates to the different states and the different populations. Another item to note as it relates to background information for the Medicaid population, level setting and understanding, I think some of the challenges that exist that Medicaid programs deal with is the fact that 5% of the Medicaid population equals more than 50% of the costs. That's not unusual for an insurance product. But what is interesting is there was a report done by the Government Accountability Office several years ago now, and it looked at diagnosis information for the most complex members in Medicaid. And it found that this data that I'm presenting here, where if you have an individual that has asthma, 24.5% of the population has diabetes, 3.9% HIV/AIDS, 65% have a mental health diagnosis, 29% substance use disorder, 7.3% a long-term care need. Now, it doesn't take long in terms of looking at this chart till you figure out that there's a lot of individuals that have chronic issues along with behavioral health needs. And in addition to that, with certain populations, long-term care needs as well. And so you see the need for both physical health and behavioral health services, yet in many instances, we know that from the delivery system, there's a lot of fragmentation that exists in terms of getting individuals' behavioral health and physical health needs met. Another interesting area for the Medicaid population is that there's 12 million, there are 12 million individuals in the United States that are dual eligible members, meaning they're eligible for both Medicaid and Medicare. And what this slide tells us is that there's some of the more complex individuals. So when you look at the Medicare side, it represents roughly 20% of the population, but 35% of the costs. When you look at the Medicaid side, it represents roughly 14% of the population, but 33% of the costs. And so you have this population, and for those that have worked with the dual eligible population, you appreciate this. And when you think about the impact that it has of, individuals being served by both Medicare and Medicaid, it means multiple payers involved in the delivery of their services. It means providers having to deal with that fragmentation of knowing an individual is being served by both Medicare and Medicaid. It means oftentimes that care managers are in different organizations that are responsible for a subset of services for that individual. And oftentimes what it means is the responsibility then falls back on the member, the individual, the patient, or their family to try and figure out this fragmentation that has historically existed between Medicare and Medicaid. Now, the good news is that over the last decade, as a result of efforts by states and some new flexibilities and authority that was created as a result of the ACA, there was an Office for Duals that was created within HHS that is working to try and break down some of the barriers. And so historically, there had been not much collaboration between Medicare and Medicaid. That's been changing, that's been evolving, but as you can imagine, in terms of two very large programs, it's complex and it takes time in terms of trying to figure out better ways to serve this population. I mentioned Medicaid services earlier. We looked at the diagram. This is Arizona specific information. I won't spend a lot of time going through it, but it just gives you a better flavor that, Medicaid is not a traditional commercial insurance product, right? You've got a variety of different services that really you don't see in terms of commercial insurance or even Medicare. So, excuse me. You can see a large percentage of expenditures for behavioral health, a large percentage of expenditures, 14% for home and community-based services, transportation, both emergency and non-emergency transportation. So this really unique array of services that are specific to Medicaid and serving the Medicaid population, or Medicaid is the majority payer in instances. And then the populations really evolved in Medicaid. Again, this is Arizona specific information, but we think about Medicaid, and Medicaid was originally created as a program to serve low income children, pregnant women, individuals with disabilities, and individuals that are aged. And now you flash forward and you look at the various changes that have been made by Congress over the last 56 years. And you see a program in which now, when you look at a state like Arizona, 50% of the population are adults. And it really results in states having to think differently about their models of care and the different populations that they're serving, and areas like housing and justice involved members and other social determinants of health are now something that states need to be thinking about from a strategy perspective, beyond just thinking about the fact that you're paying for a lot of pregnancies, a lot of long-term care services. Now there's much broader populations that are in play in Medicaid. And of course, we've all seen the data on this, but healthcare is only part of the challenge in terms of determining ultimate health for individuals, right? We have genetic predispositions, social circumstances, environmental exposure, behavioral patterns, and now, of course, I think a lot of appropriate conversations occurring around health disparities, health equity, and we'll talk more about that in just a few minutes. So when you think about Medicaid and just sort of this overview and thinking about sort of the level setting and where we're at in Medicaid today, it's a program that's expanded significantly over time, now serving over 80 million individuals in the United States. The growth of managed care has become the predominant system in terms of how individuals get served in the majority of states. It has a diverse array of services, many of which are not really viewed as traditional healthcare services, many different complex populations. And we looked at a variety of different complex populations being served by Medicaid, consuming a larger portion of state budgets. We really haven't touched on this dynamic yet, but you saw the chart where enrollment has exploded in the program. Overall spending has grown significantly in the program. And of course, as I mentioned earlier, being a federal state program, that means that state costs have grown in order to be able to continue to participate in Medicaid and meet the requirements set by the federal government. And so as a result of that, states a decade ago had about 10% of what's known as their general fund. So that's the general collections of tax revenues for sales tax, individual income tax, corporate tax. So roughly 10% of the general fund went to Medicaid. Fast forward to now, and now in states nationally, over 20% of the general fund is going towards Medicaid. And what that means is it's crowding out other healthcare, not other healthcare, but other policy priorities that policymakers may have. So when you think about a state budget, you think about K-12 education, which is the bigger piece, higher education, which is an important piece. And so as Medicaid has grown, as healthcare costs have grown, and as the state's obligations have grown to meet the needs of the Medicaid program, it means less resources available for education in state budgets. And then we know that healthcare alone does not address some of the major challenges facing the Medicaid population. So similar to what we've seen nationally in terms of overall Medicaid enrollment, this is access specific data. And you see just this tremendous growth going back to 1985 when there were 144,000 Arizonans enrolled in the program. And you saw growth occur largely through federal changes up until 1992-93. Then a plateauing, then a large growth occurring around the year 2000, which is when Arizona expanded coverage through the Prop 204 initiative at that point in time. And then a little bit of a plateauing in 2006, 2007, the economy was doing pretty well. And then you see this large growth during the Great Recession, where the access program approached 1.4 million individuals. And then the enrollment actually went down because of some significant budgetary cuts that Access had to put in place. Then with the ACA and the restoration and expansion, you see this tremendous growth that occurs over the next several years, a little bit of plateau, then the pandemic hits, and Congress provides some additional resources to states, but also tells states that you need to keep people in coverage on your Medicaid program. So states are not doing what's known as redeterminations and other things like that. So people are maintaining their coverage, but it also has resulted in that continued enrollment growth. And so that you see in Arizona today, now over 2.2 million individuals enrolled in the Access program, which is about 30% of the Arizona population. This is the Access delivery system today. So Access still maintains a fee-for-service program for the Native American population to serve tribal members who want to continue to be served in a fee-for-service program. That's a requirement from the federal government. And so that infrastructure, that offering remains within Access today for Native Americans. Regional behavioral health authorities exist today to serve individuals with serious mental illness. These programs also offer crisis services within their 3 different regions. So you have Arizona Complete Health, which serves Southern Arizona, Mercy Care, which serves Central Arizona or the Phoenix metropolitan region. And then Steward, this is an old slide, apologize for that, Mark and team, but Health Choice, need to update that, and Blue Cross today. And then Access Complete Care, the number of plans that are offered through that. And then also the Altex program, and 3 programs that offer it for the elderly and the physically disabled. And then there's the Department of Economic Security, which serves as the program lead for individuals with developmental disabilities. And then under that are Mercy Care and United, which offers physical health and behavioral health services for that population. So we're going to spend the next several minutes now focusing on a few key areas that are really, as you look forward, I think some of the strategic areas that Medicaid's going to be spending some time in, and you're going to be hearing more about here over the next many months. So the first is long-term care. And just a reminder that Medicaid is the long-term care program, the public long-term care program for the United States. Medicare has a very limited benefit, right? So if somebody goes into a hospital setting, requires a skilled nursing facility as transitional care coming out of the hospital, there's a limited benefit there. But really the majority of nursing facility benefit and home and community-based benefits are on the Medicaid program side. There has been a tremendous shift from nursing facility spending to home and community-based spending. If you go back 30 years ago, HCBS spending or home and community-based spending was really not prevalent in the Medicaid program at all. It was through the use of creative waivers to be able to create that service category within the Medicaid program. And as a result, Medicaid has been doing a much better job of allowing people to be served in the community and in their home, and nursing facility spend has come down to the point at which today the Medicaid program spends more on home and community-based services than it does on nursing facility services. As a part of the most recent $1.9 trillion stimulus legislation, there were significant new resources that were committed for home and community-based services by the federal government. And we saw recently Access submitted a 3-year, $1.5 billion plan on how they're going to spend these new home and community-based resources over the next 3 years. And so Access's plan, it's on their website. You can go take a look at it. There's a significant investment in terms of increased rates paid to providers. There's some new services that are offered as part of the plan to CMS. CMS needs to approve that plan before the state can move forward. But the state would like to, for example, to continue to allow family members to be paid caregivers. So if you're interested in long-term services and supports and how that space is evolving for home and community-based services, watch what's happening here as Access rolls out this plan. And then just as importantly, watch what happens as part of the infrastructure debate at Congress, because there's a proposal to significantly continue to invest in state Medicaid home and community-based programs by the federal government over the next 10 years. So it would continue to provide a lot of new resources for states. There's some quality requirements and the states have to develop a plan, but expect as we follow more of what Congress is debating around Medicaid and infrastructure to see a significant investment in home and community-based services for the Medicaid program rolling forward beyond this 3-year, $1.5 billion plan that Access is proposing and all states are rolling out here near term. Then this is a slide that just denotes that shift that I mentioned earlier in terms of home and community-based and nursing facility percents. So this is utilization. This is where the population is residing. And you see in Arizona specifically, the percent of the population being served in the home or in the community has grown significantly going back over the last 3 decades versus nursing facility, again, changed significantly in terms of coming down. You can't read this, I apologize for that, but when you look at the information, it shows where Arizona ranks compared to all the other states, and Arizona's a top 5 state in terms of the percent of the population that's served in the home or in the community. So again, part of the reason Congress and policymakers are making this investment is they see the value in home and community-based services. We know that populations want to be served within their home or within the community. And so part of the investment is to see if we can bring other states up and have the level of success that we've had in Arizona and other states that have been able to advance significantly in terms of home and community-based settings. Mark, I'll just stop for a second and see if there's any questions in the chat. Otherwise, I'll just keep going.
No questions right now in the chat, but that's a great reminder to folks that if you do have questions or comments, please feel free to put them in the Q&A and chat, and we can bring them to Tom during the presentation or discuss at the end.
All right, thanks, Mark. So the next section, one of my favorite quotes, we'll start with that, is every system is perfectly designed to get the results that it gets. And it's attributed to Edward Deming, it's disputed, so we really don't know who said it, but if you Google it, it says Edward Deming, but disputed. But to me, the key here is, we think about systems, we think about healthcare, and oftentimes within the policy debate, we oftentimes don't focus enough on what is the system design that's resulted in fragmented care? What is the system design that's resulted in some of the complex populations really having to navigate between different providers without a lot of support as it relates to care coordination? And so, you know, I think about this and I think about that famous bridge, the Tacoma Straits, that was built, and you know, it had this result within 6 months of opening as a result of a wind that really wasn't that significant. It was like a 40-mile-an-hour wind that blew through the strait. And it was because of the design that this bridge failed. And I feel oftentimes that's a reflection of what happens within the healthcare space. And the example that I like to use is, you know, where we were as it relates to behavioral health in Arizona. And if you look at the left-hand side of the screen, this is even a simplified version of where we were. But for individuals with serious mental illness, they had access contracting with health plans who turned around and contracted with a group of providers to meet the physical health needs of the population. And then on the right-hand side, access actually, prior to 2016, contracted with the Department of Health Services, who turned around and contracted with a payer through the REBA side, who then turned around and contracted with a group of behavioral health providers to meet the behavioral health needs of that population. And for 40% of the individuals with serious mental illness, they were also dual eligible, which means Medicare was layered on top of this. So they had a Medicare traditional fee-for-service program along with a Medicare Part D program that covered their drugs, or they had a Medicare Advantage. So an individual with serious mental illness in the state of Arizona prior to 2013 had potentially 4 different payers involved, and there was really very poor coordination for that population. And this example was not unique as it relates to the complexity faced by the Medicaid population for individuals with serious mental illness. This carve-out existed for almost all members of the population. And for complex kids in the CRS, there was an additional layer for certain services associated with the children's needs. And so we had in Arizona, I think oftentimes a system in which Medicaid became a financing arm, but there was really never a step back at how do we think about system design? And Access has been spending the last 10 years changing that, trying to drive towards access contracting with organizations that are responsible for a full array of services wrapped around a member. And that managed care organization could be accountable to delivering behavioral health, long-term services and supports, care management, physical health, Medicare services, employment services, crisis services. And so really trying to change the system design and make it more thoughtful in terms of how do we structure something to better support the Medicaid population, try to reduce the fragmentation, and support providers as well, so that they're not having to deal with 4 different payers that are involved in an individual's lives delivering services. And so, as I mentioned, over the last many years, Access has been looking to integrate different populations. So it started with All-Tex really back in 1989, that started as a fully integrated product. Then in 2013, kids with special healthcare needs, Children's Rehabilitative Services Program, took 3 different payers, consolidated it into one. Individuals with serious mental illness in Maricopa County, Greater Arizona. Then we made some changes to better serve tribal members. In 2018, it was the ACC, Access Complete Care Program. In 2019, DDD was done. That's not on this slide. And then most recently, the integration efforts around the foster care population, or the DCS population. And so, you know, given that incremental change over time, we don't have complete results yet, but one of the early third-party analyses that was done of Maricopa County and individuals with serious mental illness showed that all measures of ambulatory care, preventative care, and chronic disease management demonstrated improvement, and you see an example there. And just as importantly, all indicators of patient experience improved, with 5 of the 11 measures exhibiting double-digit increases. And the example provided there is shared decision-making increased 61%. A second example of trying to think about system design is that dual eligible population. And Access has been spending years trying to come up with strategies to have individuals in the same plan for Medicare and Medicaid. And Access has about 44% of the population in 2019 that were being served by the same organization for Medicare and Medicaid. And so you can see the population distribution in terms of other payers on the Medicare side. But the importance behind this was found in a study done in Minnesota that showed when an individual is in the same plan for Medicare and Medicaid, the same organization, there was over a 40% reduction in hospitalizations and over a 40% reduction in readmissions. There was higher use of primary care, a little bit less use of emergency departments. And so we saw the impact of care coordination as it relates to being able to build that alignment so that the individual is being served by the same organization. I mentioned social determinants of health earlier. There's a number of different initiatives that Access is currently pursuing in terms of wanting to be able to leverage the relationship it has, some of the resources that it has to improve outcomes. The first is H2O, or Housing and Health Opportunities. This is Access is requesting authority from the federal government to be able to provide and receive federal funding for rent support. So we saw the first opportunity approved by the federal government for this type of service in North Carolina, and that was done a couple of years ago. They are just starting to implement that program now, but it's great that Access is making this request. Access is the third largest housing authority in the state. It currently provides resources for over 3,000 individual placements as it relates to rental subsidies. And as you can imagine, that support, largely for individuals with serious mental illness, has an impact on their health outcomes. Access has quantified a 31% reduction in emergency department, a 44% reduction in inpatient, and a 45% reduction in total costs of care. So the argument Access will be making to CMS is this investment in terms of federal financing for housing support, rental support, can go a long way towards reducing costs. It's a similar argument that was made 3 decades ago when Medicaid started moving to home and community-based services for a select population. So I'm hopeful that through these demonstrations in North Carolina, and hopefully Arizona's can be approved, we'll see additional outcomes that can really prove the results of these demonstrations and the federal investment, opening the door for this to really become an expanded opportunity for Medicaid, for a select portion of the population to be able to make an investment to address one of those biggest needs that we see in some of the more complex individuals served by the Medicaid population, addressing housing. So that's an initiative addressing social determinants. The second is the Access Whole Person Care initiative. And one of the examples there is through Access's work with Health Current, contracting with NowPow to be able to do risk assessment and a closed loop referral system that connects the healthcare delivery system to community-based organizations. So exciting opportunities that Access is pursuing as it relates to addressing social determinants of health and trying to better connect that, the delivery of services with better data, and then also expand the services with additional federal dollars. Another area that really has gained traction, and it's been great to see, is Medicaid looking to address inequities, disparities that exist within the overall delivery system and specifically within the Medicaid population. So in Arizona, Access has created a committee to look at these specific areas. So I took this right out of the Access website in terms of what that committee is charged with, but it's to understand health disparities among Access members. So by looking at the data, really understanding where those disparities exist within the Access population, whether it's on race, ethnicity, demographics, to look at policy changes and to be able to implement those policy changes to create a more equitable system, to raise the visibility of health equity within the Access program, within providers, within the overall stakeholders, improve health outcome members. Obviously, that's one of the outcomes in terms of addressing this topic. And then identify challenges and barriers that access members have in accessing covered services. So being able to understand any cultural barriers or other systemic barriers that may exist that need to be broken down in terms of being able to create better access to care for the access population. Another initiative that Access is pursuing and has been pursuing for many years and has recently elevated the conversation in terms of having a request for information and wanting to hear back from stakeholders is around value-based purchasing. And so Access has put requirements in place with the managed care plans in terms of the percent of spend that needs to be in value-based arrangements. And Access used the Learning and Action Network, which was a federal collaboration with payers, providers, and other organizations to come up with a definitional framework of how to look at value-based purchasing. And the percentages you see here are just by the different lines of business and by different categories in terms of looking at risk and value-based arrangement. What percent of spend needs to be in different types of value-based arrangements within the delivery system? So again, Access just completed a request for information, wanting feedback back from payers, providers, other organizations. And so we'll be looking to the agency to see how they continue to try and push value-based purchasing forward in Arizona. Another exciting area from my perspective, not only in Arizona, but really nationally, is the work that's being done around behavioral health crisis systems. And so in Arizona, we actually have the most robust statewide behavioral health crisis system in the United States. When you look at the infrastructure that's been created in terms of what's funded, not only by Medicaid, but dedicated state-only resources, and it has been established by the managed care organizations in the 3 different regions. When you use the Crisis Now model of call center capacity, mobile response teams, and stabilization units, Arizona has more capacity to be able to address behavioral health crisis than any other state out there right now. It lays out a specific list of requirements that the managed care plans need to meet. There's a number of different providers that exist within this ecosystem to meet the needs, not just of the Medicaid population, but all Arizonans who may be experiencing a behavioral health crisis. And not only is this important in terms of meeting the current demands and needs of our community, but it's also critical when you look forward and the fact that 988 is going to be going live in the next year. 988 is a 3-digit crisis line that's been established specifically for individuals experiencing a behavioral health crisis. So obviously, if that is going to be turned on, and it's being turned on now already in advance of next year's go live date, there needs to be the infrastructure there to be able to answer those calls. And so 988 is going to leverage the existing suicide prevention hotline today, which takes in calls and pushes calls back out to the state in which the call originates based upon area code. So Arizona actually does the best, or one of the top in terms of all states being able to answer those calls today. And so we'll have to wait and see what state strategies are to be able to address what will probably be a significant increase in the demand of calls going forward as 988 goes live, and as there is marketing and information provided on this new 3-digit line. Congress is providing states with new funding opportunities. So through the mental health block grant, there is dollars that are being sent out to all states to look at their crisis planning, to start investing in the crisis infrastructure within those states. Congress has also provided additional funding to states to increase the percent of federal dollars that's going towards mobile crisis at a state. So Congress views the opportunity and is looking closely at how to continue to create incentives for states to expand their capacity to address crisis. Also, the home and community-based dollars that I mentioned earlier can be another funding source for states to think about as they're looking at expanding their crisis resources. And then finally, crisis systems, when they're well structured, also offer a strong partnership with law enforcement as an alternative to incarceration or the use of an emergency department. And so we've seen in Arizona, for example, in Maricopa County, there are thousands of drop-offs every year where a law enforcement will go to a crisis stabilization unit, they'll drop an individual off, that drop-off takes less than 5 minutes, and it's a much better alternative than taking that individual to an emergency department or to jail. So very interesting time as it relates to crisis as a way to address alternatives to what the existing system currently has. Another area, and I think this was elevated even more so as a result of the pandemic, is the continued need to push for better health information exchange and use of health information infrastructure. So in Arizona, we're fortunate to have Health Current. It's one of the most robust health information exchanges in the United States. It leverages Medicaid as a primary financer, but also has health plans contributing to the overall costs of the system. And so we've seen significant growth in the overall number of users. Health Current published recently some of its 2020 accomplishments, and the amount of growth that we saw in terms of utilization of the health information exchange during the pandemic was an explosive overall amount of growth. And so we're still a long way from realizing the promise of interoperability exchange of information, but hopefully we can build off of some of the momentum that Health Current has generated through its community-wide approach in terms of building a health information exchange, and we can start to see even more solutions put in place to share information between providers. Then finally, pandemic impacts and thinking about that going forward. So there was a more dramatic impact on the Medicaid population than some of the other payers, given the long-term care population served by Medicaid, and particularly dual eligibles. So if you were a dual eligible individual, again, meaning Medicare and Medicaid, you were 4 times more likely to be hospitalized than an individual who was just on Medicare. So I think it reinforced the need that we continue to look at strategies to reduce the fragmentation, to reduce some of these challenges that complex populations like dual eligibles face with the overall system design. And so hopefully we can recognize that part of the challenges that we dealt with as it relates to the pandemic, where some of the lack of coordination that exists within our system because of multiple payers and challenging flow of information. Congress helped in terms of providing additional funding to states, which really helped stabilize budgets. I think many of us felt, myself included, that right now we'd be looking at states facing significant shortfalls, but Congress, through various stimulus packages, have provided significant resources to states over the course of the last year and a half. And so that's really positioned states in a much different place than where we thought they would be. Arizona, to the credit of the Access team, responded with some creative problem solving in terms of getting new abilities to push dollars out to providers, to be able to sustain them, to be able to pay some new providers. And then I think ultimately what we saw the delivery system, not only on the Medicaid side, but throughout, respond with expansive new telehealth. And so the question going forward is, how does this expansive new telehealth result in changes in the delivery system? I think we now have expectations from patients and consumers that there be more flexibility in terms of how healthcare services get delivered. And I think it's up to payers to work with providers and others to keep that flexibility in the system, but ensure quality and ensure that we don't have overutilization of services. But it also should create a terrific avenue by which to meet some of the challenges that rural areas face and other parts of the delivery system face in terms of access challenges, access with 2 C's, not 3. So Mark, with that, I know that was a lot of information to put out there in about 50 minutes in terms of some of the trends we're seeing nationally and locally with the Access program. I'd be happy to answer any questions.
Yeah, thanks, Tom. There's a lot of great information looking at national trends, current, over time, as well as within Arizona. There are some questions, and I'll just go through them if you don't mind.
Sure, go ahead.
Our colleague and friend, Dr. Ann Newland, asked if you had any perspective on whether or not the states that have not expanded and adopted the Medicaid expansion might do so, that it took 17 years for all states to join the Medicaid program. I think so far 38 states have joined. Do you have any perspective on what might happen?
Yeah, this is a really hot topic. This is a really hot topic at the federal level in terms of how to really deal with the fact that you've got several states still that have not expanded Medicaid, meaning there is a group of individuals below 100% of the federal poverty limit that do not have access to affordable healthcare coverage. And so what is the policy solution to that? The federal government has created some pretty strong financial incentives, but there are still states that are not willing to go along with the Medicaid expansion. In fact, where we've seen Medicaid get expanded here over the last couple of years is as a result of initiatives where people have put on the ballot to expand Medicaid in their state. And so Oklahoma, Missouri, Idaho, there's a couple of others, Utah, all of those expansions have occurred as a result of ballot initiatives. And Medicaid's been strongly supported on the ballot when it gets on the ballot. The states in which we have not seen expansion occur, oftentimes it's more difficult to get an initiative on the ballot. As it relates to state policymaking, it has been a political decision not to expand. So at the federal level, they're looking at ways to, for example, offer the ability for individuals to come into the federal marketplace as a way to deal with that gap. And so I think as part of the infrastructure bill, there's going to be some provision on there, whether it's even more dollars to states to expand, or it's creating the ability through the federal marketplace to create an expansion option there for states that have not expanded. The question then becomes, if Congress goes that direction, what's the impact to states that have already expanded, right? And are there states that go back and revisit that decision? But expect something here to happen within the next many months as Congress debates its infrastructure package on that.
How about policy related to health disparity, either national policy or even policy in Arizona through access or other avenues? There have been a couple of comments that a lot of folks recognize the importance of this, want to close disparities, yet that there's often a gap between practice and conceptual framework. Any thoughts on that?
Yeah, there's a lot of thoughts on that, right? So the first is that, I mean, this is a top priority for access in terms of we've seen the creation of the committee. Director Schneider has talked about this in terms of it being a priority in looking at the data, looking at the opportunities to narrow disparities. Mark, this goes back to some of the work you and I had the good fortune to work on together in terms of some of the waiver resources that the state had pursued to try and provide opportunities for IHS and 638 clinics to be able to have a medical home option to provide more resources to close disparities for certain populations. And so Medicaid has a critical role in reducing the healthcare disparities in this country. Just about every state is having conversations around what are the strategies associated with that? What specific measures should we be focusing on? And then I think there's going to be expectations from this administration that states look at what their plans are around dealing with health equity disparities. And I think some of that is also going to roll to managed care, where states are going to be putting into not only their contracts, but they're going to want to hear from managed care organizations as it relates to procurements when they competitively procure their managed care business. What are your strategies for dealing with health disparities that exist in our state? Help identify them and help close those gaps. And so it's really going to take an all-out effort. Providers, stakeholders, payers, managed care organizations, state leaders, federal leaders. But I think the good news is this is a top priority for all of those different parties.
Yeah, thanks. Data and consistency and measures are key, of course. A couple of folks have sent some messages about that. There's a question around the topic of value and behavioral health providers and integration. And the commenter noted that we seem to still be fully encumbered with fee-for-service payment mechanisms and lots of requirements of how to do the work rather than offering flexibilities in achieving outcomes. Any thoughts from your perspective and experience on that and where the future might be able to provide flexibility?
Yeah, well, unfortunately, I mean, we still are tied to fee-for-service as the chassis as it relates to the underlying payment mechanism, even around value-based, even around risk, even around other areas like that. And so until, even if you want to have subcapitated arrangements and things like that, the requirement from the federal government is that there be some encounter level data that actuaries can point to build capitation rates for managed care that states can use for fee-for-service claims. So unfortunately, I think we're stuck with sort of the challenges of both worlds near term. So let's look at these differently, right, Mark? So let's look at the administrative requirements of how you get to value-based payments, right? And there's got to be some combination of fee-for-service, quality measures, and reporting. And at near term, I just don't see that going away. But as it relates to integration, let's look at how the system has evolved. Behavioral health providers are connected to the HIE and other data sharing mechanisms in a way that they never were in the past, right? And so they have access to more information. Payers and providers should be working together in terms of thinking about opportunities that exist. We saw Access have its targeted investment program, and so ways to better coordinate care. So let's have the conversation around value-based purchasing and some of the nuts and bolts of that. And then let's also look at what are some of the ways that the system's evolving to better integrate services, and how can that system continue to try and support providers in terms of being able to meet the individual and coordinate the care in a better fashion. So unfortunately, it's two separate conversations, and you can't evolve them to one until some of the reporting requirements change at the federal level.
Yeah, thanks. Complicated, but really important topic. Only a couple of minutes left. A few other quick questions that we may be able to direct folks to some resources for, or maybe answer here. Any thoughts on the role of 211 and how Solari's current role with the 988 interface? They're pretty actively engaged as far as I know.
Yeah, I don't want to speculate too much there, because I know Access is looking at this and they're talking about potentially a separate procurement. And so I don't want to even speculate, because I don't know fully where they're at and if this is something that they're looking to procure. But clearly, let's step back. 988, that caseload is going to increase significantly. There's going to be efforts to market that. There's going to be increased expectations on delivery systems to pick up the phone in a way that there has not been with the suicide prevention line. So, the state's going to be looking at a strategy as it relates to that. The good news on the Arizona side is it's had crisis lines that have done a good job in meeting the needs of the population, but there's also been separate lines there as well. So can we literally look to consolidate on a 988 platform, and how does that evolve nationally versus what's happened on 211? But Access is sorting that out and look for upcoming procurements around that.
Yeah, thank you. And there were a couple of comments, questions that maybe we can just note that Access may be a source of information as well as Health Current. Someone asked about where Health Current's projects may be listed, probably on their website, but there are some other resources. So if whoever asked that question wants to reach out, I can try to connect you to some of that offline at mark.carroll@healthchoiceaz.com. Happy to help with that. And then finally, there was a question around whether CMS or Access, how they'd be looking at contracting with non-transport EMS and fire for on-scene treatment. Any quick comments there, Tom, in terms of the future of some of that work?
Yeah, I mean, Access has had, if we're talking about like a treat and refer program or a community paramedicine program, Access has had that as a provider type now, and actually has had requirements in place for managed care organizations to contract with community paramedicine type or treat and refer type of providers, recognizing the value that they can bring in community paramedicine. So I would say look for that to continue to expand and not to confuse that with mobile response for behavioral health crisis, but as a way to meet 911 calls that oftentimes involve, ambulances and trips to emergency departments and fire trucks and everything else like that. So I do know that, Access has spent years trying to create infrastructure around that.
Yeah, and special note of thanks to Access for all that work that has gone on over the years and continues to go on. Well, we've reached the end of our hour. Probably still a question or two we didn't get to. My apologies, but Tom, thank you so much for that overview of those trends, what's going on nationally, for your leadership, your expertise, and your guidance as we all work forward on this, moving together. I did put a link in the chat for everyone about where you can access, that's 2 C's, but where you can access past recordings and presentations. And this recording will be available on that, as well as a copy of Tom's slides that a few folks had asked for. But Tom, once again, thanks so much. Really appreciate your leadership. Thank you for the opportunity to hear some of your thoughts today.
Thanks, Mark. It was great.
And look forward to the next session. Everyone take care, be well, and spread kindness. Bye now.
Bye-bye.